Good evening. A couple of reminders, please. Please sign in if you can. If you're a student, we need it for you to get credit for the course. And if you're a community member, it's very helpful for us to know who's here. It helps us justify having the course for next year. So thank you. Thank you, MCAT, for recording this video. We really appreciate your doing it. And you can find the presentations online at www.mcat.org. We really appreciate it if you'd fill out an evaluation sheet. It helps us know who to bring back next year and what we should do. A reminder that every student who's taking this course for credit needs to turn in 2 reaction papers to the presentations. 2 students have turned in 2 papers and nobody else has turned in any. So just a reminder. Next week, we have a great presentation. Dr. Ababa Warku from the University of Gondar in Ethiopia will be talking about challenges to maternal child health in Ethiopia. So I encourage everyone to come. And tonight, we also have a terrific speaker. We're very fortunate. We have Dr. Darin Bell, who is a clinical assistant professor of medicine with the Family Medicine Residency Program of Western Montana. Part of the College of Health Professions and Biomedical Sciences here. He also works part-time as a hospitalist at St. Pat's. He has lived and taught in Missoula for the last 1.5 years. Prior to moving to Montana, he spent 8 years living and working in rural and bush communities throughout Alaska. In that capacity, he served as a medical director for volunteer emergency medical EMS services, a national park, a nursing home, and a maximum security prison. All part of the global health spectrum. He has put together and participated in several overseas medical volunteer trips in Africa and Southeast Asia. And he will be returning to Ethiopia, hopefully as part of UN's collaborative effort with the University of Gondar. So, Darin, please welcome. Thank you all.
All right, thank you. Can everybody hear me okay? Good. Okay, so what we're going to talk about today is a little bit about the economics of healthcare. This is an area that I think needs some attention to it. We're going to talk about it specifically in the realms of global health, but this is an area that I think needs focus and attention in general. When you talk about healthcare, people don't like to talk about money. People don't like to talk about money, period, in general. But when you're talking about healthcare specifically, if you go to the doctor's office, the doctor doesn't really talk to you much about money. I am a doctor. I don't particularly like talking about money and the problems or issues that it may be involved with it regarding someone's health care. Patients don't particularly like to talk about money. They certainly don't like to talk with their insurance companies about money if they've got them. They don't want to have those conversations. Insurance companies don't like to talk to doctors or patients about money. They'd prefer, as far as I can tell, just to take it and not pay, period, and not have anybody ask. But the simple fact of the matter is, when you're talking about healthcare anywhere in the world, money is really one of the driving factors and one of the things that you have to think about. In global health, that becomes even more important than in the health of developed nations. So if you're talking about underdeveloped or developing nations, it becomes even a bigger issue. And we're going to touch base on that a little bit and try and explore some of the reasons for that today. So here are the things that I'm hoping to cover. We're going to talk a little bit about what we mean when we're talking about healthcare in general. What are some of the inequities in healthcare that you'll find when looking around the world at different economies and different societies? Healthcare rationing. Healthcare rationing gets a lot of press and a lot of attention at times. We're going to explore that a little bit. What does it mean and why is there rationing of healthcare? The effects that economics and economies in general have on healthcare, and the effects that healthcare has on local and global economies. The effects of health systems in different areas, how they affect people's health, how those systems are arrived at, and how that may be affecting a particular region's health of its population. Barriers to changing, to addressing some of these issues. And what are some steps to make movement, things to improve to try and decrease some of the problems associated with healthcare, particularly healthcare for the poor in global environments. I'm going to relate a lot from my experiences, as Dr. Fitch mentioned in the introduction. I've traveled to multiple different locations on volunteer trips in the past, worked through some great organizations. This spot right here is Indonesian Borneo, a small town of about 5,000 people, which this volunteer clinic has been set up and is running in an attempt to help educate local providers. This is one of the hospitals in Malawi that we worked at, working with the University of Malawi and educating actually went over primarily with my wife, who's Jen here in the audience, educating their physical therapy department and physical therapy trainees. And then this is the waiting room to Black Lion Hospital in Addis Ababa in Ethiopia. This is the main governmental hospital in downtown Addis Ababa. And we spent several weeks working there, both at that hospital and at another hospital set up by private donations. So I'll bring some information in just from experiences and things that I've seen in these environments. If you have any questions at any point, I have lots of pictures in this presentation. If you have any questions about anything specifically, feel free to stop me. If you have any questions at any time, feel free to stop me and we can chat about things. So first, let's start out. What is healthcare? What do we mean when we're talking about healthcare? Does anybody have any ideas? This is the audience participation time. Thoughts? Healthcare? Healthcare? Nobody knows. What's that?
Having access to information and preventative care.
Having access to information and preventative care. I think that's a great start. Okay, healthcare absolutely involves that. Any other thoughts? What else does healthcare involve? Apparently nobody has ever been ill or has never been born in the United States.
Like a risk reduction strategy?
Okay, so risk reduction. Yeah, I think that's perfectly valid as part of it. Other thoughts? Yeah, in the back.
Treating existing illnesses.
Treating existing illnesses. Perfect. And that covers most of the big things. So the WHO did a study or an analysis to determine what basically is involved in basic healthcare coverage. And this analysis was looking at what would it take to provide universal coverage as part of their Millennium Goals. The idea was and I know the new Millennium Goals were just released, but their prior Millennium Goals was to provide, one of them was to provide basic healthcare coverage universally by 2015. We obviously did not achieve that goal, but we're going to talk about that a little bit. But in their analysis, they said basic healthcare coverage essentially should involve healthcare promotion, prevention, treatment of illness, and rehabilitation, which y'all hit upon the top three. Essentially, rehabilitation is the third point. Once you treat the illness, what do you do with somebody afterward? How do you get them back to their former state? Obviously, healthcare cannot involve or universal coverage for basic healthcare cannot involve all aspects of all parts of these things. The details of what's involved and what's meant by this, I'm not going to get into in this talk because basically we could spend hours and hours discussing it. But this is the kind of general framework that we're looking at when I'm talking about global healthcare at this point in time. So, in general, global healthcare over the past several decades or longer has been on a steady improvement. The quality worldwide has in general been going up, which is a great thing. There still remain, however, giant inequities between certain regions and within certain regions. And there are a lot of reasons for that. There are a lot of barriers to care that we're going to touch on in just a little bit too. But as my title might have hinted at, we're going to focus mostly on how the finances come into play in this. So the WHO in 2010, as part of their analysis and their Millennium Goals, did an analysis of 49 low-income countries. And these are the lowest income countries, including Indonesia, Ethiopia, and Malawi, which are the ones that I've spent time in, to try and determine what the cost of universal basic coverage would be. Anybody have any guesses how much that would be? Throw out a number.
In just these low-income countries?
Yeah, in low-income countries. It does vary quite a bit from region to region. So we're talking about in low-income countries.
Per capita?
Per capita.
$100.
$100. Any other guesses?
50?
$50. You're all in the right ballpark. $60. $60 plus minus 20. So the range was essentially 40 to 80 depending on the country when looking at low-income countries. Now this will vary quite a bit, like I said, because of a whole lot of reasons. The infrastructure that's available, what resources are there, that sort of thing. Again, we're not going to get into those details, but this is the ballpark number that we're thinking about. So to put this in a little context, if we're looking at the GDP, the gross domestic product per capita, in Ethiopia, $505.05 annually. In Indonesia, $3,475.25. In Malawi, $226.46. So there's obviously a wide range of variability in terms of how much $60 per person per year is going to affect the economies of each of these countries, or how much effort it's going to take to come up with that sort of cash. In the United States, any guesses what our GDP per capita is? I'll give you a hint. It's a lot higher than these. $53,041.98. Okay, and this is all based on World Bank estimations from 2013. So these probably vary a little bit by now. Healthcare spending per capita. In Ethiopia, $25. Indonesia, $107. Malawi, $26. Any guesses for the United States? How much are we spending? $25,000 per person per year. That would be very impressive, but it's actually not all that far off. $9,146 per person per year in the United States. So obviously there are huge differences between developing countries and developed countries, between poor countries and rich countries. But there are also some pretty significant differences among the developing countries as well. $25 and $26 are pretty consistent. $107 in Indonesia is quite a bit higher. Yet there are still large inequities within Indonesia, and we'll touch base on those a little bit here as well. So just doing the math, taking the numbers from the last two slides, in Ethiopia, the percent of GDP that's spent on healthcare is about 4.9%. Indonesia, it's about 3.1%. And in Malawi, it's about 11.5%. In the United States, 17.2%. On average, if you look at developed countries or wealthy nations, they generally spend about 7% of their GDP on healthcare. The United States, as we all have probably heard, has some unique characteristics to its healthcare system that probably drive up the cost of spending. And whether those are good or bad, I'm not going to get into the political discussion here, but we do have a significantly higher spending per capita per person. Interestingly, we don't have the highest outcomes per person, but that's a whole nother conversation for another point in time. So that brings up the question of healthcare rationing, okay? If there's this little money that's currently being spent, like I have to click back through, sorry, $25, $26 in Ethiopia and Indonesia, then rationing becomes an issue, okay? Why is that? What is rationing? We hear about it a lot in the context of healthcare. It comes and goes in waves at times. In the political spectrum in the United States, rationing most often comes up as the context of some really evil thing that's going to destroy your doctor-patient relationship and take away all your rights to be treated when you're sick, and or involve death panels, which will tell you when you're going to die. But if you look at definitions of rationing, these are just 3 definitions pulled from different resources. They all basically deal with how do we distribute limited commodities when the demand outstrips the supply. So why is healthcare rationed? Because it's a limited commodity, okay? If you have only a certain amount of healthcare available, and everybody could use healthcare at some point in time, because although many of you are probably young, healthy college students that still think you're immortal, you're not. So something's going to go wrong at some point in time. You're going to need healthcare. This happens whether you're a rich person, whether you're a poor person. We all die eventually. This happens whether you live in a rich country or a poor country. So if there's a greater demand than there is a supply, there's going to be rationing of some sort or another. Now, sometimes this is going to be rationed based on dictates, based on legislation, based on societal statements of this is how we're going to provide the distribution of this commodity. Sometimes the rationing just ends up by default because nobody really has paid attention to it, and so the rationing is just there because that's the way it's been, because we don't have enough resources available. In the United States, how is healthcare rationed? You all probably have a pretty good idea about this. How do we ration healthcare in the United States? Because we do, currently.
Poorly.
Poorly. Okay, I'm not going to go down that path, but how do we ration healthcare in the United States other than poorly? By who can afford it? Insurance and wealth. Ability to pay. That's basically what it boils down to. If you don't have insurance, if you're not independently wealthy, then you have a more difficult time getting access to care. So the clinic that I work out of is Partnership Health Center, which is a federally qualified health center with a mandate to help treat people who don't have the means to pay. Okay? This is a big problem. If you don't have the means to pay, it becomes a huge barrier to care, both in the United States and in developing countries. The conversations I have to have with patients on an almost daily basis include, these are the things that I think you should do. How can we make that work with your budget? There are restrictions in the United States on who you can see, on what clinics you can go to, on what hospitals you can go to. Even if you have insurance, your PPO, your HMO, your ACO, they will all tell you who are on their approved lists of people that you're allowed to see. Restrictions on what medications you can get. Your insurance. I guarantee if you have insurance, it's got a formulary, and it's not going to say, we'll pay for whatever medication you want to take. They're very, very restricted, and it's very common that insurance companies will send a message back saying, or a pharmacy more often will send a message saying that medication you prescribe for a patient is not on their formulary. Is there something else that you could prescribe instead? Basically, what do these boil down to? Ability to pay. Again, if you're a trust fund baby and you have unlimited wealth available, you can go out and buy whatever medication you want. You can go out and pay cash and see whatever doctor you want to see. But most of the world does not live in that particular situation. These sorts of situations are magnified in developing countries. So when we're talking about healthcare rationing in developing countries, what are we talking about? It most commonly goes by another term, because whereas in the United States our system is set up with various institutions that ration through their mechanisms, what happens in developing countries? What do we talk about most commonly? It's barriers to care. Okay? It hasn't been a developed system that says we're going to say who gets care where and what, for the most part. For the most part, it's been the organic development of healthcare in those countries with their resources and their environments, and the difficulties that people have accessing that care for one reason or another. So barriers to care involve a whole lot of different things. Lack of access, lack of funding, lack of facilities, lack of training for providers, lack of providers due to lack of training, cultural issues, knowledge issues, educational issues, gender issues, low quality care. What do these all boil down to? When you get right down to it, lack of access, lack of funding, lack of facilities, where's the money coming from? To pay for more facilities, to pay for more access so that people can get into healthcare. Lack of training and lack of providers. We've got to be able to train those providers, which takes resources. You have to have funding for education. You can make the argument that cultural barriers, knowledge and education barriers, and gender barriers are also due to lack of education of the people, not necessarily the providers, but the people themselves who are accessing the care. And in large part, that's because there aren't resources for that education. Low quality care? Low quality care is a little bit of an interesting thing. If you don't have funding to train providers, then the quality of care goes down. If the quality of care goes down, it becomes a bit of a cyclical issue, because if the quality of care goes down, people don't make use of that care, then the funding gets cut for that care, then the quality of care goes down even farther. But basically it boils down to the funding ability to pay for that care to keep the quality up in one way, shape, or form. So again, you're going to notice a theme in this discussion. We're talking about money. We're talking about how finances affect care, particularly in the developing world. Yes?
You're right on, but I think the additional barrier to care in much of the developing world is political instability.
Absolutely.
Also related to funding in some ways, but
Absolutely. Political instability. And I think that it would be a whole different discussion, but I would agree with you in that there's a big effect that has on funding. Because most situations, at least that I'm familiar with, in areas where there is political instability, neither side has as a stated goal, we want to prevent people from getting health care. We want to prevent people from being well. But it uses a lot of resources, the political instability can, and resources, when they're diverted to things like civil wars and infighting and that sort of thing, they have to come from somewhere else. And if the resources are limited, if funding is limited, then it frequently comes from healthcare, among other things like education, like sanitation, like infrastructure, and that sort of stuff too. But that's an excellent point. So, if healthcare is a limited resource that has to be rationed in one way, shape, or form, what is the effect that economics has on deciding how that healthcare is rationed? There are a number of things that I want to touch base on here. And I'm going to find my spot in my lecture notes here to make sure that I'm not missing things that I wanted to cover, because this gets a little more detailed. Number one, technology. Healthcare technology is changing all the time. This was a machine that checks CD4 counts. So if you've got HIV and or AIDS, your CD4 count is one of the measurements of how severe your illness is. This was in Malawi in a regional hospital. It was actually this was an interesting hospital. It was set up by a donor organization, but then was incorporated by the government. And so it's now a local regional hospital in Malawi. They had an extremely large laboratory room with absolutely nothing in it other than this CD4 count machine, because they spent so much of their time. In Malawi, about 10% of the whole population is infected with HIV, and so much of their time and efforts were aimed toward HIV treatment and management and reduction of transmission and that sort of thing. This sort of machine is really expensive. Part of the reason they had nothing else in that lab is because this is the only thing that they could afford to have at the time. So technology is expensive. Unfortunately, new technology often does not replace old technology. It's an additive process. So the CD4 count machine did not replace the need to check blood counts overall. It did not replace the need to check other laboratory values on patients. It's in addition to address this specific problem of HIV. New technologies are always expensive when they come out. Expensive technologies are really hard to justify providing in areas where they will either be used very little or where they don't get the maximum amount of effectiveness from them. So distributing new expensive technologies to areas where there may be a great need, but it's not as great as somewhere else, is a barrier. People may have a clinic. They may have the ability to receive some sort of care, but they may not have access to adequate care because the standard of care changes over time. Next, logistics. This particular hut was at the end of a path like this that we had walked on for 45 minutes before we arrived at this hut to see one particular child patient. If you're living in a situation like this, or if you have to travel down this road over these bridges for 4.5 hours in a four-wheel drive vehicle to get to a village to set up a mobile clinic in a hut like this, logistically it becomes impossible to provide a persistent level of care in these locations. It becomes very difficult for the healthcare providers to provide that care. It becomes very difficult for people living in those situations to access care if they don't have care readily available. Just not only the logistics of walking down the path, driving down the road and getting it there, but the maintenance, the resupply, all of the things that go along with that become very difficult. The vehicle that we traveled in, these things got beat up non-stop to go to do these mobile clinics over these roads. I mean, there was at this clinic that I was working at, there was a full-time staff person just maintaining the 2 vehicles they had. They had 1 ambulance and 1 truck. And they had to have people just maintaining them all the time because they were continuously falling apart. We had to have professional drivers to drive us because it was so treacherous and problematic driving down those roads. So the resources that required go up to get to places without infrastructure. It becomes very logistically difficult. This seems to have stopped working. Economies of scale. Okay, this gets back to what I was mentioning about the technological issue. If you have very limited resources, this is downtown Addis Ababa. If you've got a situation that looks like this, where the urban slums and the people living in shacks made out of corrugated tin and blue tarps are just everywhere, all over the place, all of those people are just as poor as people in rural areas. All of those people have the same difficulty accessing care. If you put your technology, if you put your clinic, if you put your hospital in a location like this, you're going to have a much greater impact on people. That doesn't negate the issues that people have in more rural areas. Okay, so just the economies of scale, the need to maximize the use of expensive technology, of maintaining equipment, of keeping up facilities and things like that becomes much easier to do. And so you get a disproportionate distribution of healthcare as a result of that. This is to represent people with money tend to be the people who have the influence in the way policies are made. So when discussing where to put in a new hospital, when discussing where to put in new care, it's not the poor people who have a voice at those tables. The poor people who have to walk 30 minutes or drive 4.5 hours, probably don't even have a car, don't have a voice in those conversations. Okay? This is not to say that the people with the money who have the influence are deliberately doing things to exclude those people. But if you're making decisions as to where healthcare needs to be, and you say, we can put in a new hospital and there are lots of people around here who really need access and it will provide me care as well, well, that's an influence. That's going to be in the back of your mind. It's hard to avoid those sorts of thoughts. And you can always justify it saying that we're providing a lot of good for a lot of people. And they're not wrong in that respect, but it does influence how healthcare is distributed throughout economies, throughout regions, both in developed and in developing worlds, or countries rather. I'm going to start using this because that's not working. So let's look at things the other way around. What are the effects of healthcare on the economics of a situation? Okay, this is to put it in a little frame of context. When you're poor, your health tends to be worse. There are distinct differences based on socioeconomic status on outcomes of things like infant mortality. This was in the clinic in Indonesia. This is actually a scale. This is a really cool baby scale. So they had this, essentially what was a little hammock hanging from a little just spring-loaded scale that they hung from a rope from the ceiling. Or it wasn't spring-loaded, it was a balance beam scale that they hung from a rope in the ceiling to weigh their babies in the clinic because it's all they had resources to. I thought that was actually really cool. But infant mortality goes up. Certain cancers go up. Stomach cancer and breast cancer are 2. Strokes go up. Lots and lots of things tend to go up as your economic status goes down. So let's put this in a little context. So what does that mean in terms of the economies? Well, A, if you're poor, you're disproportionately hit by the costs of healthcare if you have to pay out-of-pocket costs yourself. Okay? If you have to take time off of work, and if you don't work, you don't get paid. If you don't get paid, you don't eat, and your family doesn't eat. That makes it a very difficult choice. Do I take time off of work to travel however far I have to see a doctor, to see a healthcare provider of one sort or another? Or can I just delay this for a little while and see what happens? If this is your primary source of income, if it provides milk for your family and milk that you sell, and that's the primary way that you're able to support your family, but the only way you can pay for your health care is by selling your goat, that's going to be a huge problem for you. It's going to cause a whole lot of second thoughts in terms of how should I approach my current condition, my current problem. In addition, if you get sick or if you have a problem, it can have a severe impact on how productive you are. If you're fishing for a living, what happens if this guy breaks his arm or this guy breaks his arm? It's kind of hard to row. You can row a boat in little circles, I guess. Might make it difficult to catch the fish. Throwing a net out or pulling it in becomes significantly more difficult as well. So productivity goes down. If you've got a chronic diarrheal illness and you're having to stop whatever your work is every few minutes because you're having to go to the bathroom, productivity goes down. If your stomach hurts all the time, it's really hard for you to focus and stay engaged and productive. So these things will directly impact not only your immediate economy of you and your family, but the whole local economy. If you're not producing as much, you don't have as much to sell, that money doesn't get distributed to other people in the economy, and it has a ripple effect throughout, particularly in poorer societies. Children. Healthy children learn better. If they've got full bellies, if they're not dealing with festering wounds, they can pay attention to their studies. They can focus on what they're learning. They gain more information more quickly. They tend to do better in school. When you do better in school, your education goes up. You tend to have a better chance at a good job. You tend to become a more productive member of society. So again, this moves on up. This was an interesting program with the Indonesian clinic we went at. This was one of the workers there. He was actually one of the drivers too, which is kind of cool. But he was teaching children how to do organic farming, which was one of the outreach programs that they had going on at that clinic. This is another little slide. This isn't a direct effect of healthcare on economies, but it is a manifestation of healthcare and the economics of individuals and their situations. If you're extremely poor, if you're living in a situation like this, in a hut like this, with basically nothing around you because all of your land has been deforested for either production of the hut or for installation of a palm plantation that's going in, or because it was your only means of income was to cut down trees and sell it, and now you have nothing, and then you have some sort of catastrophic health event, you do manage to make your way to a clinic or to a hospital, you don't have the resources to pay for that care, and then you're sent away. Psychologically, that is an extremely powerful manifestation of poverty because you're at your most vulnerable at that point in time. You have absolutely nothing, and now you're sick, and you're going for care, and you can't get it. That has an extreme effect on your particular situation, your particular outlook, which can have rippling effects through the psychology of the whole family. But it's just a manifestation of poverty and the effects that economics can have on it, and it can have on economics. Effects of systems on health. I want to spend a little bit of time talking about how healthcare systems affect health in general, because the last couple of sections of slides we're talking about how the economics of an area affect healthcare, and healthcare affects the economics of an area. This is more the health, because healthcare and health are not necessarily the same thing. Healthcare is an aspect of working toward good health, but it doesn't necessarily equilibrate 100%, which we'll touch on here in just a minute. But this slide was just to show, this was actually on that walk out to the hut that I showed earlier. This is probably about 25, 30 minutes down. We passed this nice little yard with these two graves in it right here. But this was to remind me of the differences in mortality in general. So with poverty, I mentioned that certain cancers and chronic diseases and health problems go up, the mortality rate goes up as well. Now, the first time I heard this, I thought, wait, isn't the mortality rate 100% regardless of what your economic status is? Everybody dies eventually, right? But the likelihood of dying at any given age is higher if you're poor. So if you're 30 years old and you're poor, you're more likely to die than if you're 30 years old and you're rich. If you're 40 years old, same sort of thing, and on up the scale. Eventually, yes, it does catch up and it does even out. Ultimately, mortality rate is 100% across the board, unless somebody's hiding something that I haven't heard about yet. But when you're poor, your mortality rate goes up at all age brackets. So you're dying earlier and you're dying more frequently at earlier ages. I guess I just said that same thing twice. With wealth, you're more likely to make use of healthcare systems. Okay, this equal sign should actually have been an arrow. Okay, this was actually a really interesting study that was done in Australia. There was a large survey that was done of Aboriginal Australians versus people who were relatively well off living in cities. And they asked a basic question: how healthy do you think you are? How sick do you think you are? Universally, the Aboriginals living in absolutely poverty-stricken situations thought they were generally pretty healthy, thought they didn't get sick all that often, and things were going pretty well. Much more so than the people living in higher wealth environments, which is interesting because objectively, the people living in the Aboriginals living in the destitute or the poverty-stricken situations were far less healthy. They were dying earlier. They had far more disease problems going on. They had far more issues with health in general. So there's not a direct correlation on self-perceptions of health with actual objective measures of health. But there is, interestingly, this correlation between how much money you have and how likely you are to think that you're sick, which also translates into how likely you are to make use of healthcare. So wealthy people tend to make use of healthcare more often than poor people do, in part because maybe because they think that they're sick more often, in part because of some of the barriers to care that we talked about. This also comes to play a role when you're talking about public versus private healthcare. So in a lot of developing countries, as in a lot of areas in the developed world as well, there's a dichotomy. There's somewhat separate healthcare systems, and most healthcare systems worldwide have a mixture of public healthcare and private healthcare, set up to different proportions in different areas. If you're poor, you're more likely to make use of public primary care. If you're rich, you're more likely to make use of private primary care. However, that tends to switch as you move up the chain of care. So by the time you get to tertiary care, by the time you're getting admitted to a big referral hospital, if you're rich, you're more likely to make use of public than you are of private. And there are probably a lot of reasons behind that, but partly it's because of the expense. Private hospitals are far more expensive than public hospitals, and once you're getting into the big referral centers, generally the public hospitals are pretty good because there are resources available for those. So that's probably part of the issue. But what this ends up doing is it provides a system where overall, because tertiary care is so much more expensive than primary care is, you end up with a system where the public resources to public health care end up flowing more to the rich than to the poor anyway, because the rich are more likely to make use of the healthcare services, and they're more likely to make use of the public healthcare services in the more expensive settings. And so this is frequently the case. Now, this is not 100%. You can find situations in cultures and countries where these are actually switched, where there's more use of private healthcare, and then there's debate about whether making use of local healers and traditional healers and things like that is actually making use of private healthcare, which poor people are more likely to engage in. So there's a whole lot of nuance and complexity to this, which I'm not really going to go into right now. But it is an interesting perspective that overall, the use of public funds into healthcare, if they're not distributed in a very conscientious manner, oftentimes end up offsetting the cost of the wealthy as much or more as they do of the poor. So what are some barriers to changing these systems? Okay, so these are issues that come up with regards to economics and regards to the problems that poor people or people in developing world have with their health. What are some of the barriers to improving this, to improving these outcomes? Well, one would be this. One is just what are the resources that people are using? What is the knowledge that they have? What's the education level that they have? Poor people, like I just said a second ago, may be more likely to make use of traditional healers like this, rather than to go to a hospital. If your hospital or your clinic services in your area are non-existent or extremely poor, low quality, this is more likely to be the case. Well, we've got traditional healers that for generations have been taking care of us and things we think that we're relatively healthy, so let's make use of this. Although that doesn't necessarily provide the best quality of care overall. Lack of resources. If you don't have doctors, if you don't have facilities, then people don't make use of these things. If you don't have the funds to train doctors, if you don't have the funds to build facilities, then people don't have the option to use them. So this becomes not only a barrier to care, but it's also a barrier to change. How do you get the money to improve these things? And there are lots of steps that people can do to improve that. In Ethiopia, for example, where a contingent is going in another month, they're opening up 5 new family medicine training programs across the country, and their goal, I just learned this today, is to open up 800 new regional hospitals we didn't get a time frame, but sometime in the relatively near future, which is hopefully going to open access to care significantly. But they had to dedicate a significant amount of resources and funds to make that happen. Again, people with money have the influence. People like the status quo if it's serving them well, okay? It may not be malicious, but if my care is okay and I see that we have care, we're providing care to the poor, I don't necessarily feel that it's hugely needed to take care away from me to give to someone else. And so that makes it very difficult to change in certain societies and certain situations. Societal inequalities that are inherent just as the society has developed. Doctors typically come from upper classes in the developing world. They're the ones who can afford the schooling. They're the ones whose families don't have to have them working so that they can go get further education. Nurses typically come from working classes. They come directly from the people in the poorer environments more often. Doctors get reimbursed more. Doctors have more money, doctors have more influence. The resources tend to get focused on doctors. When people talk about lack of access to care, people tend to think, I don't have a doctor in my area. The impacts that nurses can have with direct care in local environments, in terms of primary care, in certain ways can exceed the overall impacts that doctors can have, simply because they have the ability to see people and deal with more basic things. So if you're dealing with diarrheal illness and hydration, that's going to be a much more cost-effective way to provide a significant improvement in the quality of life and care for an individual than if you're dealing with a renal transplant, a kidney transplant in a tertiary care hospital. Okay? So the ability to improve care at the basic level is not necessarily where the focus is right now. And so this culturally has to shift to a certain extent as well to start making big changes. And it's not necessarily a doctor-nurse inequality, more a primary care, tertiary care issue, and a distribution of care overall, and where are you getting the maximum effectiveness for your resources. Health promotion and health prevention is often not adequately focused on in the developing world. These are things that don't have direct, tangible benefits in the immediate sense to an individual patient. And so it's harder for people to see the advantages to putting resources into this area. This picture is in Malawi. It's a play that was put on that was actually started by a nonprofit initially, but then they've received some government grants to continue doing it. And now they actually have multiple troops that are putting on this play, which is all about HIV awareness. And so this is actually the final scene of the play where his girlfriend has died of AIDS. But the point is, they can take this troupe of a handful of actors and go out to lots and lots and lots of villages and talk about the importance of use of a condom, talk about the importance of knowing your HIV status, talk about these things that will help prevent transmission of HIV to hopefully help lower the rates. And there are direct impacts that this has from a societal level. going out and watching a play like this is not going to cure your HIV. It's not necessarily going to prevent you from getting HIV in a direct sense, but it decreases your likelihood as the culture starts to shift. Cultural issues are also interesting. If you're poor and you don't have a lot of health education, you don't know a lot about what healthcare can provide for you, and you walk into the store and you see that, oh, I can buy diabetes rice. Well, maybe that's what I'll do. It's got a big thing on it, says it's diabetes rice. It's got to be good for diabetes. If I can buy my Pure Joy guava juice, maybe that's what I need to be drinking because that's going to help me out. And maybe that's where I should focus my money instead of focusing it on going to see a healthcare provider. Okay? These sorts of things, health promotion, health prevention, health education in general, can make a huge influence on individuals over time. The cyclical nature, like I talked about previously. If you have a resource that's underutilized, it begins to be difficult to maintain and upkeep, keep it supplied. The quality tends to go down. It begins to look worse and worse. People stop going because it's not looking so good, because the quality of care is bad, which further provides an influence to say, let's not fund this because nobody's using it, which then cyclically it goes down and down and down and down and down. Funding. I showed you earlier what the GDP of Indonesia, Ethiopia, and Malawi are. I showed you what they're spending on their health care. Is it reasonable to expect that if it costs $60 a day in underdeveloped countries, to say, you just need to shift your priorities in these countries and come up with the $60 a day instead of the $25 a day that you're spending on people right now? Is that a viable option? Countries still have to provide for infrastructure. They still have to provide for military services, for police services. They still have to provide for their roads, for shipping. They still have to provide for all of the other things that people need to survive in that country. To over double the amount of resources that you're putting into healthcare is a huge jump. And if you don't have a very large economy to begin with, that can be a really problematic thing. So that's a big barrier to shifting things. So what can we do to help? So one would be, well, we can improve GDPs of local economies. Well, I talked about how healthcare directly affects the local economy and how the local economy directly affects healthcare. So how do we break out of that cycle to start boosting up GDP? Well, it's a bit problematic when you start getting into the details of it. However, there is a correlation between increased GDP and increased health of the people of that society, with some caveats. So it's to a point. Once you surpass a certain level, that sort of starts to trail off. However, also, if you control for the amount of poverty in a country, okay, so some countries may have a very high GDP. So that was the issue with Indonesia. Indonesia's GDP was significantly higher per capita than Ethiopia or Malawi's GDP. But they still had horrible problems with healthcare. Their expenditure on healthcare was a little bit higher. But if you control for expenditure on healthcare and you control for how much poverty is in the country. So Indonesia's wealth was not at all evenly distributed across the country, and there were huge areas of high levels of poverty. If you control for those things, the effects of GDP that GDP have on health actually tend to disappear some. So while that may help to a certain extent, it's really logistically difficult to figure out how to do that. Countries are obviously always wanting to increase their GDP. And it's not necessarily the end-all and be-all of the solutions to fix the situation. Shifting healthcare from tertiary healthcare centers, shifting the focus from tertiary healthcare centers to regional primary care centers is a huge way to improve the global health. Using the same amount of resources but shifting the focus can make a difference. This picture was a person who had a motorbike injury. I think it was about 1.5 years prior. He had a displaced fracture of his leg right at the knee, and it had healed up this way. He had no means, his motorbike was wrecked. He had no means of getting to a healthcare center. And it wasn't until he developed this pressure ulcer from the bone pushing out from the inside of his leg that his family finally said, you got to come in and be seen, and took him the distance that it required to get to a healthcare center. So had there been locally available resources for him, he might not have been in this situation. He might have. There still could have been resource issues in terms of access to care. But had he been able to get into a clinic, a local clinic, have somebody set the bone, he might have avoided this situation entirely. He also might have been able to be much more productive for himself and his family overall. User fees. This is one of the most controversial topics in terms of improving access to healthcare. And there are arguments on both sides. I just wanted to bring it up because it is a topic that comes up fairly regularly. So the idea behind user fees is that A, it promotes an investment in your healthcare. If you have to pay something for it, you're more invested in maintaining it and taking care of it. B, it helps to stabilize the finances of a healthcare system. So if you have fees coming in from the people who are using a clinic or a regional hospital, that can go directly back into that clinic and regional hospital and help ensure that that care remains there. C, and this is a somewhat controversial aspect of this, but it helps to enforce societal norms which can help people to buy into reforms. So people with money who have good access to care, there's a certain aspect of that people with money feel like they should have good access to care. If you have a small user fee involved, it preserves that feeling of, well, I can pay for it, I can have access to care. That helps prevent the idea that people have that, well, you're just taking my care away from me and giving it to somebody else who's not been paying for it. The theory behind this is that, well, if you institute something like that, then people are more likely to say, well, let's increase resources to people who don't have them because they are invested in the system, they are helping to provide for it. Whether that works or not, that's a big issue. We talked previously about the economic effects on healthcare, or the healthcare effects on economics. This does nothing to improve the situation where you have to sell your goat to get your health care, where you have to get rid of your entire means of supporting yourself or your family to pay for your health care. So that's why this is such a controversial issue. Some people really feel that user fees are very important in terms of improving access to health care overall. Some people feel that they absolutely should be done away with completely. But it is a topic that comes up. Yes?
Just a comment that that's a first world cultural norm that's totally inapplicable in the developing world.
I would say yes and no, except these arguments do come up in the developing world.
And they come up because the World Bank promotes user fees, and they come from the developed world mentality.
Yeah, yes and no.
The key to look at is what percentage of the population is in a position to afford user fees.
Right.
And if you go to many developing worlds, you're looking at 2/3 of the population that has no ability to pay user fees.
Absolutely. And the lack of ability to pay user fees is the strongest argument against them. So yes, I would agree that that frequently comes up as an argument primarily in the first world. And yes, I would agree we have certain institutions which tend to propagate that particular argument. The argument does come up in local situations as well, and again, I think it gets back to who has the influence in the decision-making process. It's not the people who don't have money and don't have access to get into politics. It's the people with money who do, and so I think the argument does come up locally as well. That being said, yes, those are valid points. Yes?
So I disagree with you a bit on this, Chris. I think that a very small user fee, if you keep it just nominal, can play an important role. And along with that, you can also introduce a system of micro-insurance where people collectively pool their funds to be able to pay these very nominal user fees through a micro-insurance kind of scheme. So I'm not part of the World Bank, and I don't agree with a lot of the things the World Bank says. But in this particular case, I think a nominal user fee is important because it does that important thing of vesting you in the system. That's a very important part of it.
And this is why the controversy exists. Yes?
Why don't we let him finish, and then we can talk about it.
Yeah, I've only got a few more slides, and then we can get bogged down in the weeds all we want. How's that sound? Yeah. So the last thing that I want to talk about here is just sustainability of the resources. So if you have an extremely low GDP per capita, and the likelihood of being able to raise your expenditures on healthcare up to the roughly $60 per person becomes very, very slim to non-existent. How sustainable is that? Is it realistic to say that the economy should just shift their focus? A lot of people would argue that that's not the case, and we need to be looking at long-term sustainable funding sources from other areas. And this is an argument that has become fairly popular recently. That rather than providing grants or short-term funding options to improve infrastructure, to improve facilities, to provide for materials or provide for training, we really need to be looking at whether it be through charitable organizations or whether it be through redistribution from developed countries directly into the economies of developing countries, some way to help provide external funding until developing economies can build up to a point that they can sustain them within themselves. Again, similar to the user fees, this is controversial. There are lots of arguments for and against redistribution of wealth globally in terms of healthcare. And I don't want to get bogged down in those particular discussions either. But this is another area that people talk about, the other primary area that I would say that people talk about in terms of, or are starting to talk about in terms of how do we improve the access to healthcare globally overall. So, take-home points that I just want to bring things back around is healthcare inequities exist, whether in the developed world or in the developing world. They're everywhere, whether it's because of institutionalized systems that ration healthcare versus whether it's because of the way systems have developed that the barriers to care ration the care in and of themselves. Rationing will occur in all of these situations because at the current time, we don't have enough healthcare to go around. There is not a supply of healthcare to satisfy the relatively endless user demand because it's a self-perpetuating user demand that goes on. So rationing has to occur in some way, shape, or form. Economics obviously directly impact the healthcare of people, especially poor people. The healthcare of people directly impacts the economics of a region. Current healthcare systems, because of these economic impacts, directly impact the health of the people in those systems. Lots of barriers to changing the provisions of healthcare. I apparently mistyped that. And there are steps that are being looked at, some of which are fairly straightforward, some of which are fairly controversial as to how to improve the access to healthcare globally, particularly for people who have serious problems with poverty and access to care right now. However, that's why I put this last comment in here, the best process to improve that access and to improve overall health is extremely unclear. Lots and lots of people have very strong opinions about this from polar opposite perspectives, but it's something that I think we need to continue to address and work on. Any questions about any of that? Yes?
So you've clearly had a pretty diverse experience, and so I'm curious as to what you think. And I think it's important to keep in mind that you have to consider like geographic location, cultures, all of those things that you mentioned earlier. But have you seen a system that you think might be more effective and more generalizable than others? Or what in particular have you seen that has been really effective?
I think it's very challenging. The systems that I've worked in and that I've seen in those three countries particularly, none of them have been very good. All of them are very, very heavily focused on the large referral hospitals and the tertiary care centers. And some of the care that you can get in some of those areas is quite good. Some of the care you get in large tertiary care centers is terrible still. But the resource allocation to local areas, to district areas, to spreading it out toward and addressing the primary care issues is universally difficult in the developing world because of all the reasons that we discussed. So I haven't seen a system in the developing world that I think is particularly good right now, which is why it's a fairly universal problem throughout the developing world. You can get into all sorts of arguments about in the developed world what systems are better or not, and that all systems in the developed world have been going through changes over the last several decades, shifting toward, some systems shift toward more public involvement, some systems are shifting toward more private involvement, and there's pluses and minuses to all of that. But I haven't seen anything that I could say, yes, this is what you need to do to improve the access to care, other than there needs to be a shift in focus to more distributed primary care. Yeah?
I have not had the opportunity to work in these truly impoverished areas, I'm in South Canada, I'm in South America. And it appears to me that the key there for us is helping bolster the public health systems that are developing. They need us to do educational programs, to send specialists in to work with their specialists, I mean, they have an infrastructure, but they don't have the people, they don't have the money invested in it. But there's room there for improving the quality. And also, and you mentioned this when you're talking about doctors and nurses, in most of these countries, the real key is developing the community health workers of various types of them, whether they're maternity aides or, because you're right, you can't go out to all those shacks.
Right.
They can.
Yeah, I would agree, and that I think is involved in the shift of focus toward primary care. And primary care doesn't necessarily mean primary care by a doctor. Primary care can mean a community health worker, it can mean a nurse, it can mean any level, sort of mid-level, any level of provider that can provide direct access to a larger number of people, ideally at a lower cost. And so that's where actually some of the different levels of training, like nursing and community health providers, community healthcare workers, can actually come in, because their reimbursement is not as expensive as physicians are. The training and the quality of care, I agree, and in many situations there really does need to be a boost in that. I would argue that the infrastructure is not always there. And so to just train and provide for more higher quality trained physicians or providers of one sort or another isn't the full answer, because if they don't have the facilities and they don't have the infrastructure to practice healthcare, then that becomes an issue too. And I think that needs to be addressed, particularly when you're talking about the more rural areas. In more urban areas, it tends to be that the infrastructure is there, and you can actually make a pretty big impact if you're talking about highly densely populated urban areas, and I think that that can be a big effect on it. But in rural areas, I haven't seen, in the areas that I've been in, adequate infrastructure available in general. Yeah?
Thank you enormously for your talk and the preparation you've done and the subject of your talk, because I think money it's all about the money, it really is. In terms of user fees, I think that there clearly are some benefits to user fees. The biggest one is the accountability it introduces between the people who receive the money and the people who spend the money. So the facility is now responsible to the patient has something invested. But even the World Bank at this point is no longer supporting user fees, because they constitute the biggest barrier of access to care for the bulk of people who don't have money. So I think, and European health systems by and large have moved away from user fees. So I think there are, if you have the capacity in country to identify the poor and discount their user fees, and that's a pretty sophisticated capacity, and most of these poor countries don't have that ability, it can make sense. But by and large, health systems have moved away from user fees.
Interestingly, one thing that I did find with regards to user fees, and I'm not going to wade into the argument pro or con against user fees, is it can actually take different forms. So the clinic we worked at in Indonesia did have nominal fees for patients, but if patients didn't have money, they could provide them with mats or baskets that then the clinic would sell, which they could collect grasses and weave into mats or baskets, and the clinic would sell. They could provide eggs or manure for their organic gardening outreach programs. They could go into the forest and find seeds for certain hardwood trees for reforestation projects. And so that in and of itself is a type of user fee, but it's a very different type of user fee than actual cash fees, which can be extremely difficult for some people to come up with. So there are a number of options along those lines, I think, that could potentially be explored, but there's
Just one other comment.
arguments for and against.
We're critical of these systems, but they're funded on, $50 per person per year. The whole country's national system is funded on hardly anything. So I think it's naive of us to judge these systems as being poor quality for some reason other than lack of funding. I mean, that's barrier number 1, 2, 3, and 4.
Yeah.
Yes, for any given degree of financing, there are better and worse performers, and you can improve performance. But the funding is such a major issue, as well as not just funding for health, but roads and communication and logistics and all those things. And in particular, the human resource issue of qualified health workers is so dire in Africa, where, nurses are paid $25 a month, and they can make a lot more doing informal private practice or emigrating or whatever. There's that's such a major bottleneck and constraint to quality care that it's worth understanding.
And
It's about the money, too.
I agree. There's a lot about that. I would also say that that's not isolated to developing world as well. I've worked in areas in the United States where the access to care is absolutely every bit 100% as difficult as some of the most remote areas. Now that, we could talk about off-the-road system Alaska, which is a completely different situation, but I think Dr. Miller, who's in the audience, have you talked yet, or is your talk coming up? You talked already, yeah, about the sort of issues that come up with the problems of the same sorts of problems in the United States that arise as well. Yeah.
Darin, I'd like to echo what Nancy just said about your theme, and I think that you really put your finger on the key issue, and you've stimulated a lot of thinking, and that's great. One of the things you didn't mention, and I'd like to get you and Nancy both involved in this discussion, when you talk about redistribution of wealth, there are a lot of efforts that are going on right now. For example, the Gates Foundation is heavily involved in that kind of thing. But one of the problems is they tend to be silo kinds of approaches, and they're devoted to one particular illness or one particular dimension of the healthcare problems that poor countries face. I think what Nancy, I've heard her speak before, what she makes a very compelling argument that the redistribution of these funds should be more broad-based, in the sense that it should go to basic healthcare systems. That's where the funding should go. You didn't address that question, so how do you feel about that?
Yeah, and this is part of the last point in steps for improvement, the coming up with resources for the healthcare systems in general. I think this is one of the issues, because you make a valid point. The Gates Foundation puts in an enormous amount of money into malaria research. While malaria is a huge problem in much of the developing world, in northern Siberia it's not an issue at all. And it's very focused on one particular disease process. The argument can be made, and I think has been made by a number of people, that focusing that more on sustainable or long-term contributions toward improving access to care globally would have a bigger impact than looking into one specific disease process. My general feel is that we need funding to look into specific research, specific problems, because otherwise we're not going to find solutions to those. But the flip side of that, I think we need far more funding into the provision of care in general at a most basic level. And this is not, we're talking about even getting away from access to a healthcare provider, but just access to sanitation, access to clean water can have a bigger impact overall. And if we don't get those basic things covered universally across the board, then, well, we can fight off diseases one step at a time, but it's not going to have the same sort of impact on global health that if you improve access to basic healthcare needs is going to overall.
I think it's a really good point that you made, because
way more people in the developing world die of diarrhea and non-communicable diseases, but it's not nearly as glamorous to raise money to prevent diarrhea as it is my mom's church back in East Texas raising money for 500 bed nets that can help prevent malaria. It just seems better. And so there is this distribution of where people want to put their focus, and it's not necessarily where you can make the biggest impact and changes of public health across the board.
Yeah.
At the Mansfield conference yesterday, there were a number of speakers talking about money. But not talking about using money in this way. They want to use high-tech IT stuff and complicated genomic studies in Japan. And it's all good stuff. But how do you balance that? If the big money wants to go where the big money is, if you will.
Yeah. The people with the money have the influence. And so it really is. I think it speaks to what Jen was just saying. The sexy causes get the attention. And it's easy to rally around a particular problem or a particular exciting new potential thing to do. It is nowhere near as easy to say, we need to raise money to get more nurses or more community health workers available for 17 villages in Uganda or wherever. That's a harder thing to do. I think framed right, you can rally some support around it. But I don't think one should necessarily be at the expense of the other. I think that both are valuable areas to look at. I just don't think that there's enough focus on this particular aspect of where global resources are going at the current time. Yeah.
I just wanted to add that I thought that the decision makers and how the money gets distributed, to me, is almost the most important thing here. So in the United States, for example, there's a lot of difficulty accessing primary care, tertiary care. There's no way we're going to be able to ration that in order to pay for broad primary care. I mean, that's a big part of the healthcare debate over the last 10 years. And probably going forward as we continue to try to work on that. But it's even, in my sense, it's even worse in developing countries where you have actually some pretty nice hospitals, like in Guatemala City. We worked at a private hospital that was, I don't know, it's not quite as nice as St. Patrick's Hospital here, but it's pretty darn nice. And if you think about the money that got spent on that hospital as opposed to the public hospital that we also worked at, it's just so different. And if you just put money into a system, the decision makers are going to funnel it to the places that serve their interests. And I'm just not sure how you could get away from that if you tried to just in general put something into a system. And I think that's why it's earmarked for specific things. It's the only way that you're going to get workers on the ground in some rural area educating around HIV prevention, because you earmarked it for that. If you didn't earmark it for that, it would build a new tower at the nice hospital in the capital.
And I think that's a really valid point, similar to the HIV you just mentioned. You know, the people who live in cities with adequate irrigation and drainage and mosquito control, pesticide distribution and that sort of thing, who are at lower risk for malaria, aren't necessarily going to focus general funds on malaria because it doesn't directly impact them as much. And so having the research and having the efforts going into malaria for the same sort of reasons, yeah, I agree. It does need to be earmarked to a certain extent. I think my personal bias is that we need to earmark a whole lot more for improving access to care. Other questions or comments? Yes?
I'm from Global South, I'm from Bangladesh, and sorry for poor English. Very interesting, the presentations, I was enjoying that. And I want to share some information from Bangladesh context is that. Oh, by the way, I'm here in a part of the Hubert Humphrey Fellowship Program. I'm Catastrophe International Center here. I'm very new, just last week I joined the university.
Welcome.
Yeah. Very interesting presentation and questions come up here. So my country, Bangladesh, is a it is one of the poorest countries, that our health expenditure. I was Googling here, I see that only $25, it was 10 years back, and right now $32. Our people are spending per capita health expenditure. As per the World Bank statistics, I see, I don't know whether it is correct or not. I don't know. You have presented the WHO statistics. Anyway, so comparative, almost close to Malawi or other countries. But what is the interesting thing is that if you look back in 20 years or 30 years, once we are very little, we have seen that people are used to die because of simple diarrhea. And our life expectancy was at the time only 40 years. Only 41 years. But by 20 years, we have improved our life expectancy. Right now it is around 60 years, like that. So 20 years we have improved. But in that context, the per capita health expenditure, maybe $10 or like that, has increased. Maybe that will be interesting. You have raised the issue of the diarrhea issue. You see, we have some innovation in health system, health services in our country. You may have heard about the International Center for Diarrheal Disease, ICDDRB. This is an international center. You know that a very simple solution our people innovated, like some sugar and salt and water, and that can give the big solution, and that can save the life of our people. And we are doing those. So these are one example of innovation in health services that we have innovated, we are designing, we are doing practices. So this is some information to share with you. And infrastructure is still in our rural area. You imagine that 160 million people in Bangladesh, 160 million people in Bangladesh. So we have very few little access to the health services and expenditure and infrastructure like that. But I think we need the innovation we should encourage the innovation in health system services or health services. Thank you.
Yeah, and I would agree with that. And I think the focus in Bangladesh on the diarrheal illnesses and the significant improvements that it made, because that probably had a direct impact on that 20-year increase in life expectancy, is huge. But I would agree, and I would argue that that's a focus on the primary care, the base of the problem, because diarrheal illnesses affect huge numbers of people and are imminently treatable. And the oral rehydration solutions that are now readily accessible and easy to use, that the World Health Organization has also been involved in putting together and distributing throughout the world, I think can make a huge difference. Innovations in those sorts of situations, appropriately focused, I agree with you completely, can make a significant difference. It also brings up a point that I didn't get into during the slides, but some countries are able to significantly improve their quality of health and quality of care without significantly increasing the expenditures that they put into the healthcare system. Some countries increase their expenditures into the healthcare system dramatically and don't make any difference whatsoever in terms of the quality of health and quality of care that's provided in them. And so it's not as black and white as it may have appeared. There are a lot of subtleties, and it depends on where the focus goes and how that money is spent. So in the initial slides that I put up with figures from different countries, Indonesia was spending 4 to 5 times as much on healthcare as Ethiopia and Malawi. It was spending well over the $60 that the WHO says is what's necessary to provide a certain basic level of care to all people. But Indonesia has the exact same problems as the situations that we were seeing in Ethiopia and Malawi. And it's because of the distribution, in part. We didn't spend time in Jakarta, which apparently has fantastic health care available for people. But where we were in Western Kalimantan and Borneo, there was zero healthcare available for people. And so how it's distributed also makes a big difference. Yeah?
To expand this gentleman's point, historically, the last 100, 150 years, the biggest impact on health, not healthcare, but on health, is public health. It's clean water, it's nutrition, it's educating women so that they know how to control their numbers of children and keep the children they have alive. It's not how much you're spending on hospitals.
Absolutely. I would agree with that completely. And I think I would include that in the health promotion and prevention aspect of healthcare. But whether you call it public health and sanitation, whether you call it health promotion and prevention, however you want to distribute it, it's that basic fundamental educational aspect that probably more than anything else plays an effect. Yeah.
I think this is a great example of a local innovation that can really make a difference. And I really agree with what you had said. But I think that the contrast is between what they did in Bangladesh and genome research that you're talking about, that millions and millions of dollars are being spent on today. So what we end up with is an even more divided world than we have right now. And I think that's where these things are important. I think genome research is great, but the priorities are screwed up. And that's why we have in this country spend so much money on health, and yet we have such little to show for it, especially among our poorer parts of our population. So it's the priorities that need to be addressed.